We are facing challenging times with the recent outbreak of coronavirus. The World Health Organization identified COVID-19 as a global pandemic, and the President has declared it a national emergency due to the speed and scale of transmission. Because of this, the Secretary of Defense has directed travel restrictions for the next 60 days for uniformed members, our civilian teammates, and our family members.
This includes all forms of official travel for non-essential personnel to include PCS, TDY, and government-funded leave. This also includes personal leave and other non-official travel. We know this impacts you and your families, but your safety and wellness are our top priority. We can't stress enough how important you are to our team. COVID-19 is serious. It's highly communicable and has already affected many countries. A disciplined sense of urgency is essential.
Each one of us has a personal responsibility to do all we can to help minimize the spread of this virus. We must all take personal hygiene and health protection measures as outlined by the CDC seriously in order to safeguard ourselves and our loved ones.
Our approach is simple. We need to take care of each other while we protect our fellow Americans. If you show symptoms consistent with COVID-19, immediately seek medical care and evaluation.
You can find more information and resources at cdc.gov, af.mil, and spaceforce.mil. We'll continue to post the latest information and keep everyone informed. You'll know what we know. Let's tackle this challenge as we do all challenges which confront us.
Thank you for your continued service and your professionalism. Fights on.
The virus that causes coronavirus disease is spreading in some of our communities. This disease, also known as COVID-19, is thought to spread mainly from person to person through respiratory droplets produced when an infected person coughs or sneezes. These droplets can spread to the mouth, nose, or hands of people who are nearby, or possibly be inhaled into the lungs. Take steps to lower your risk of getting sick. Here are some things you should do. Wash your hands often with soap and water for at least 20 seconds. You can also use hand sanitizer that contains at least 60% alcohol. Take extra measures to put distance between yourself and others. Avoid close contact with people who are sick. Stay home if you're sick, except to get medical care. If you have severe symptoms, please call 911. Cover coughs and sneezes with a tissue or the inside of your elbow. Only wear a face mask if you're sick and around other people, or if you need to take care of someone who is sick. Clean and disinfect frequently touched surfaces. Older adults and people who have severe chronic medical conditions like heart or lung disease or diabetes are at higher risk for more serious illness from COVID-19. This group should consult with their healthcare provider about additional steps to stay protected. For more information on COVID-19, please visit cdc.gov/COVID-19. Let's work together to protect ourselves, our families, and our communities.
Okay, ready to go? Okay. Well, first of all, thanks a lot for being here today, especially under the circumstances. You know, nothing more important to get out in clear communication, and you perform an incredible role for doing that, not only for our internal audience, the Air Force, but also for the nation. You know, Secretary Esper's priorities have been crystal clear for us. We categorize them as people, mission, and partnerships. And so what I'm here to do today is talk to you a little bit about how we as an Air Force are responding to the virus. So we're still conducting global missions around the globe, which is priority one. We've got fighters, bombers, maintainers deployed, working to keep America safe, and we're still flying global mobility missions and conducting global space operations. So in the global missions that we as an Air Force support and the Joint Force, all those missions continue. We're also focused, as you might imagine, on conducting a nuclear mission, managing 2/3 the triad, and of course the nuclear command and control in support of Admiral Richard. And we are keeping our training pipelines open, and I'd be happy to talk about that in Q&A in terms of some adjustments we're making to keeping those pipelines open. As Secretary Esper has reminded us, our focus first and foremost is on people. And that's not only our active, our guard, or reserve, our civilians, but also in the communities in which they live. We've communicated with all echelons of command. Some of you may have seen an open letter to commanders I put out this past week, and just emphasizing to them that that communicating is as important as anything else we do. I do have some folks that are with me that I'd like to introduce to you. First of all, Lieutenant General Dorothy Hogg. Dot is our Surgeon General, Air Force Surgeon General, who will help me out with any kind of medical detail questions. Our lead of the crisis action team in the A3 is an Air Force reservist, Brigadier General Rob Blake. He was here as well. And then Lieutenant General Brian Kelly is our Air Force A1 Director of Personnel. So with that, we'd be happy to take your questions.
Okay, Bob.
General Bob Burns with AP.
Hey, Bob.
Good morning. How many members of the Air Force currently have been confirmed to have the disease? And also, what are your advisors telling you at this point about looking ahead maybe even 1 month from now or 2 months from now? What percentage of your force do you think might be incapacitated by this?
Yeah, right now numbers are small. Knock on wood, we've got 7 active duty cases that we have right now. You know, as Secretary Esper said yesterday, you know, we are generally a younger and physically fit population, so tend to be a little bit more resistant to the virus. So not surprising to me that our numbers right now are low, but we're taking it very seriously, and I'll call Jill Hogg up here to talk to you a little bit about the next month and what we're seeing in the future.
Yes, sir. So we do know that our cases will increase just like they are in the general public, and so we are paying attention to those cases and identifying contacts and implementing measures to decrease exposures. So social distancing, doing single point entries into the medical clinics to make sure that we're separating the two populations if someone were ill.
But do you have any projection of how many might, you know, be incapacitated by the disease even a month from now?
So the projections are difficult because there's a lot we still don't know about the virus. We do know that the virus is highly infectious and that the virus does infect anywhere from one person can infect 2 to 2.5 other people. And so we're looking at that and using that as our planning factor.
So you don't have a figure at the
I
moment?
do not.
Okay, back there. Sorry, go ahead, Vivian.
I'm Vivian Mashi with Defense Daily. Thank you for doing this. I wanted to ask you about the status of the Advanced Battle Management System experiments that were supposed to happen in April and for 3 months thereafter. Can you share whether it's been delayed, the April one specifically, and what's going to happen from now on?
Yeah, thanks, Vivian. It's actually been postponed till June. So right now, really important that we're not canceling it, we're postponing it, and we're because you know there's a number of industry leaders that are also involved in this. With this, you know, we in April were postured to take the entire joint, all the Joint Chiefs were going out, Chairman, Vice Chairman, all of the Joint Chiefs were going out to be part of the demonstration. We want to put that back on in June. Right now, so it's a postponement versus a cancellation, and then we want to make sure we get right on track as soon as the conditions allow us to.
Okay, and is Dr. Roper and the Air Force at large, is there anything that they can do in the interim to continue the experiment, even if it's not the massive demonstration that he was hoping for.
Yeah, so what we're doing is using the time to advance some of the technologies, because, when we did this in December, we had 26 of 28 of the different line elements that we were working on work. When we got back and did our after action, we actually thought that was too many. Maybe we didn't stretch ourselves. So this one is significantly larger. We're trying far more new things and trying to connect capabilities that are not currently connected. And so we're going to use this time to advance those technologies so that we can even try more things. If we get this right, about 60% of it will work. 40% won't work at all, and we'll learn from that and we'll move forward. So we're doing this in every 4 months, and so this one has been delayed.
Okay, let's go to Marcus on the line from Defense One.
Can you hear me okay?
Yeah, go ahead, Marcus. You got it.
All right. I just wanted to ask, how is the Air Force helping to ferry around coronavirus test kits? Is the Air Force playing any type of role in it?
Yeah, we are. As a matter of fact, we had a meeting with the Secretary of Defense, and one of the things we talked about was our global mobility capacity for moving personnel supplies throughout. You may know of a mission that we are currently involved in, moving test kits, all in support of Homeland Security, to make sure that we are Health and Human Services, to make sure that we're meeting the demands that they have. So, one of the things that we have is a rather robust global mobility portfolio. We do this all, Marcus, working with and through Transcom Commander, who has that responsibility, and the Transcom Commander is closely connected with Health and Human Services to make sure we understand their demand signal.
Okay, let's go back to the room. Tara?
Thank you, sir. One, can you tell us if any of your bases have had test kit shortages, how testing is going on base? And then secondly, for keeping flying missions current, getting everyone their hours, as you know personally, a cockpit can be a pretty close quarters place. Are you taking temperatures of pilots? What sort of steps are you doing to prevent the spread among your aviators?
Yeah, so right now we haven't seen or had a report from any of our wing commanders on test kit shortages. I think to a large extent, if you go back to the numbers of cases we've actually had, 7 across the Air Force active duty-wise, we haven't had a significant demand signal yet for test kits, but we are, like all the services and like the nation, looking at test kits overall in terms of what we may need to see in the future. In terms of, can you repeat your second one again?
For pilots, how are you keeping
yeah.
this in such close quarter?
Yeah, so early in this process, I talked with General Marianne Miller, who's our Air Mobility Command commander, because global mobility into and out of level 3 countries has to continue, and so she has measures in place that isolate the crew, mitigate the risks, so we can continue to fly into, knowing that the global landscape will change, right? Level 2 countries will migrate to level 3. This is going to be a changing dynamic, and what we've got to do is to continue to, even if you're a level 3 country, like let's say Italy, Aviano Air Base has still got to fly. They can't fly unless they have parts. They've got to have continual supply, and so we got to keep this global mobility mission running, but not only inside the Air Force, but I can make an equal case for the Army, the Navy, the Marine Corps. We do the much of the resupply, so she has procedures in place, and she's working those along with the Transcom Commander to make sure we can keep global mobility up and running.
Could you describe a few of those procedures? Like, do they involve taking temperature of crew or?
They do. Screening, temperatures, isolation in terms of social distancing. We consider the aircraft itself a clean environment. And so while they're in that aircraft, the longer they're in that aircraft, they're actually in an environment that is not of a concern. It's when they leave that environment to go to their rooms or what have you. So we're really minimizing movement and keeping them in a bubble, if you will, to make sure that we can keep the force size we need to be able to maintain the missions.
Okay, let's go to Valerie and Senna from Defense News on the line.
Yeah, can you hear me okay?
Yeah, go ahead, Valerie.
So I kind of wanted to check in following up on Tara's question and see if you had any broader concerns on the logistics or supply side of the house. So, like, for instance, has the Air Force been able to order what it needs from a medical standpoint as far as, like, really mundane items? Is it able to buy the food and necessities needed to stock commissaries? And then are you guys able to get the supplies and parts that you need to continue to do the flying missions that are your bread and butter? So, like, where are you seeing any challenges or pressure?
Yeah, thanks, Valerie. You know, with respect to, you gave the example of commissaries, you know, all the other base support facilities. We're working to manage that at the local level. So the letter I put out, the note I put out to the wing commanders really stressed that our job is to arm them for success based on open communication so we know their needs. So right now, in terms of stocking commissaries and other on-base facilities, we're able to meet the need going forward. Obviously, that's an ongoing dialogue as the dynamic changes going forward.
Okay, back in the room, Laura, and then over here.
Hi, Sarah. Laura Seligman with Politico. Can you please talk to us about the capability of some of your mobility aircraft that have this infectious disease capability? I know I've seen some mods that roll on, roll off.
Yeah.
Are you preparing to use? Are you currently using that capability? Are you preparing to do that? And then also, do you have any Air Force medics who are coming out of school or already in the field who are preparing to relieve civilian hospitals right now?
Yeah, thanks, Laura. So first of all, we actually had this conversation with the Secretary and the Chairman. You know, as we look at the different capacity that each service brings, one of the things that we bring is aeromedical, and we do have the capability of not only using existing aircraft, but we also can modify. You know, not only in the air but also on the ground, right? In terms of being able to take a facility and turn it into a expeditionary location. We do that in combat all the time. So I'm going to ask General Hogg to sort of give you more specifics on this, on the kind of kits we have and what we're looking at. In terms of medics, you know, one of the things Secretary Esper mentioned yesterday, and it is very much playing out, is that you know, many of our medics are actually reservists and are therefore working in the local communities. And so, as Secretary Esper said, we got to be really careful, and we're working this really through the states and the adjutant generals in terms of, you know, when I would take and mobilize or bring them forward to support the community when they're actually also already in the community. You know, how do we manage that so we mitigate risk? And I think the overall philosophy that you're seeing from the Department of Defense is that our medical capacity is best used for trauma care. So the way we're looking at it is what could I offer up that the Secretary could then offer to HHS or to a governor that would actually take on trauma cases, you know, gunshot wounds, things, right, that actually then frees capacity in the civilian medical community to be able to handle the COVID response. That's the way we're approaching it. Dot, anything on the kits?
Yes, sir. So on the transportation part of it, so the core mission of the Air Force Medical Service is air medical evacuation. And we do have the capability to transport contaminated patients. And so, but that is directed by Transcom. So we would allow them to task us to do that. So we do have that capability.
Can you say a little bit more about the capacity you have? I mean, how many beds could that equate to potentially?
It all depends on the situation and the criticality of the patient. And so if they are less critical, I can move more at one time. If they're more critical, I can move less. And I have the medical support staff who have been trained in this transportation isolation unit to be able to handle those patients.
Okay, let's go back up to the front row.
One more thing. Hey, Laura, one of the things that you're going to find, I think, from all of us is that in terms of total numbers that equate to capacity, we're not talking those because very often they're actually also tied to operational plans. And so we don't give total capacity in terms of the number of beds, number of docks we have in that.
Thank you.
Thanks.
Reese from Reuters. One specific question: if you could give a bit more detail about the sort of the transportation of the test kits and sort of how that's playing out. How many numbers are we talking about? And more broadly, obviously, you've talked about the force being young, but exercise is obviously being postponed. Training is being affected. At what point do you think this starts affecting the force, or is it indefinitely just going to not affect the force?
Yeah, So on the transportation of test kits, we're linked up with, again, with HHS, and they're really driving the demand signal. And then our capacity from a global mobility standpoint, we're not limited because we can move a lot of test kits on a C-17 or a C-5. That's not the issue at all. The issue really becomes, competing requirements, right? If I'm going to take a mission and use it for test kits, some other mission is not going to get serviced or is postponed. That's what Transcom does every day. So I don't see any limitation in terms of our ability to move the test kits and the things that HHS is asking for. On the exercises, they do have an impact. Right now, we're early enough in terms of the number of exercises canceled that it's recoverable, right? So I'll give you an example. Red Flag Alaska was scheduled to go in May. We just canceled that. That was within the last couple of days. That's a few hundred folks that come to Red Flag, which is for the Air Force, our National Training Center equivalent. It's where we do our highest end training. There is an impact for those that were scheduled to go there. We canceled it for a couple of reasons. One, to allow those units to focus at home on dealing with COVID-19. But what I anticipate happening is we will put in place procedures to actually be able to continue exercising, albeit perhaps at a lower rate in terms of numbers, by bringing social distancing and the other CDC protocols in play. And each combatant commander has been given the authority by the Secretary of Defense to determine whether he can continue an exercise with local forces. Given the fact that we've pretty much stopped movement, right? So for instance, if the EUCOM commander, General Walters, wants to continue an exercise and he can get his objectives met with local forces, he has the authority from the Secretary of Defense to move forward on that, just knowing that I'm not going to be sending him forces from outside of that particular area going in. And I think what you'll see is we'll make individual decisions on a rolling calendar as we look at every exercise.
How many test kits have you moved so far? How many test kits have you guys sort of transported so far?
I'll have to do that and find out. I know we've just made a pretty significant movement into Memphis last night or day before. But tell you what we'll do is let me get you the number if I can.
Yeah. Okay, let's go back out to the line again. We'll go to Nick Schifrin from PBS and then back into the room. Nick, go ahead. Are you still there?
Sorry, I was muted. Can you hear me?
Yeah. Go ahead, Nick.
So just two questions. One, about that movement. Thanks for doing this, by the way. About that movement, you mentioned at the top the seriousness, the importance of maintaining access to level 3 countries. Can you talk a little bit about how much movement you still have that's deemed mission critical, despite the overall guidance, obviously, to minimize movement? And in terms of social distancing, you talked about the clean environment that is the aircraft in general. Can you talk a little bit more about social distancing that you're doing among senior officials all the way down? Thanks.
Yeah, no, thanks, Nick. So first, in terms of movement and what's coming up ahead, what we've done is lashed up our, in typical military terms, we call it command and control, right? So how are we organized for success here in a supporting response, in a supporting response to Health and Human Services? So the Vice Chairman and the Deputy Secretary are leading the Department of Defense effort. They plug into the Vice President's task force, and we have an element with HHS that then helps define the requirements and then communicate those requirements over to the Department of Defense when it's a DoD ask. And so right now we are not seeing any limitation in our capacity to meet those movement requirements, especially when we're talking about small test kits where we can put multiple numbers on a large airplane. So we work those requirements daily. So I don't have a good number for you because I expect that every day we're going to get a new requirement that we're going to meet through Transcom. And then we talked already about how we're going to continue those missions by taking steps to mitigate risk with the crews. You asked about senior leadership. So, just to set the example, for the Air Force, I actually, with my Vice Chief and the Secretary of the Air Force, we are actually doing telework. So, I've got Monday, Wednesdays, and Fridays. I actually did telework from the first time yesterday and spent all day, as you might imagine, working this particular issue. And we're sending a message to every echelon of command in the Air Force that if the Chief of Staff of the Air Force can do it, then they can too.
Do you have from home? From home?
Yes. And the good news is I've got everything I need, both classified and otherwise, to continue to stay connected.
When did you start that?
Yesterday. Did it all day.
Okay.
Yeah, Mike Flynn with the Washington Times. You mentioned about needing spare parts. I was wondering, how are you dealing with the issue of parts? Because you not only do you have corona concerns, I assume the companies that make the washers and spring, they also have it. Is that causing a problem with that and contracting at this point now for you? And
yeah.
Can you extrapolate, I mean, how long can you go?
No, it's a great question. I can tell you that that Secretary Lord, Ellen Lord, is leading that effort, at least in the Department of Defense. She and Mr. Gertz and our acquisition leader, Will Roper, are all looking at the industrial base to look at impacts to keeping our parts supplies on. Right now, to date, we've not seen a limitation that's caused us to pause or affect operations in any way. But this is a concern going forward, because companies have got to figure out how to keep their lines open with their own social distancing and own procedures to be able to protect their workforce. And so this is a constant communication that's led by Secretary Lord with industry leaders to make sure that we can keep the trains running.
Okay, let's go to Bloomberg. Tony Capaccio.
Hi, sir. Can you hear me?
Yeah, Tony.
Okay, during the Ebola crisis, General Silva at Transcom developed an isolation chambers to put on planes, and now those are part of the Transcom mission. They're called transport isolation systems. Can you give a sense of how many of those are in the Transcom inventory and whether those could be used in extreme situations to move patients from locations to location?
Yeah, thanks, Tony. I'm going to ask Jill Hogg to come up.
Yes, sir. We do have the transportation isolation systems. We do have a limited number of them. I really don't want to go into the specifics based on O-plans, but we do have the capacity to transport COVID positive or any other biologically contaminated patient through Transcom.
Yeah, let me check though, and roughly how many can be transported on a C-17 or a C-5 or a C-130? Just to bound that a little bit, we're not talking scores, we're talking individuals, right?
Yeah, you're talking a relatively small number, less than 10 for each one of these kits, if that helps. And
not a panacea to move people. That's the point I wanted to make.
Yeah, that's right. And the other thing, Tony, I would share with you is that we got to look at the full spectrum of potential movements, right? There's everything from the fully positive, symptomatic to, and what the Secretary Esper has asked all of us is in both a fixed wing and a rotary wing capacity perspective. What is it that we could bring should HHS come to us with that request? And we have that analysis ongoing.
Okay, thank you, sir, and good luck to you.
We're going to go to the back of the room, and then we're going to go to Brian Everstein on the line after that. So please go ahead, ma'am.
Colorado Public Radio. Thanks for doing this. I have two quick questions. One, and I know it's only been like 5 days, but have you given any more thought about when the cadets might be coming back to the Air Force Academy? I know some colleges and universities in Colorado have already said that the spring semester is not going to happen, and they'll be coming back in the fall when this is all over. And the second is, how does this affect deployments? How Air Force deployments going out? How will this affect people coming back and going out?
Yeah, thanks, Caitlin. First at the Academy, so we're talking obviously with the Superintendent, General Silveria, and he's talking to their superintendents, and he's got a wider discussion going on with university presidents because really this is a university issue with young people in close quarters where it becomes very difficult to actually distance them from each other. I mean, we have 2 people to every room, sometimes 3. So he made the decision. I approved that, working with the Secretary. Secretary Barrett approved that to allow him to send home the lower 3 classes, but keep the first class. We're on spring break right now. The first class will come back because we need to get them through graduation in May. So that's our focus right now. The others are already talking about distance learning. The dean is working through distance learning, and they'll make a real-time determination on when we think that we can mitigate the risk to the point where we can bring the cadets back. And obviously, we're tracking this in terms of being able to keep each class on time. So this is really a broader university-wide discussion that we're having on taking the right actions. On deployments, we're defining, per the Secretary's guidance, what are mission critical activities, right? What are those mission critical activities that we have to sustain and maintain to be able to do what each of the services brings to the joint team? So whether that's nuclear deterrence or global mobility. And so as we define something as mission critical, those deployments will occur. There has been a specific restriction on movements for the next 60 days, per the Secretary, on movement into and out of level 3 countries. And so we're working through that daily. What's important to know is that there is an exception to policy that the Secretary has delegated to the first general officer in the chain, whether that be in a combatant commander or service chain, to be able to authorize an exemption to that stop movement for purposes of being either mission critical, humanitarian, hardship, something that would cause that general officer in writing to approve that waiver or exemption that exists.
Okay, we're going to go to Brian on the line, and then we'll be able to take 2 more questions after that. So Brian, go ahead.
Thanks again for doing this. You had talked a bit about keeping your global missions flying. Can you talk about the impact of flying hours locally at your local bases and maybe your weapons school and keeping their readiness high as opposed to going to a drop in readiness that followed sequestration? And separately, can you talk about how you're addressing social distancing at places like air operations centers or air crews that are sitting alert that are usually really co-located but mission critical?
Yeah, thanks, Brian. I'm asking to answer the second one first, if that's okay, and that is, as we look at mission-critical activities, we have a number of I would call them operational headquarters, like the Theater Air Control Center that runs all global mobility, the Air Operations Centers who are running ongoing combat operations. Those are facilities that have people that are generally in close quarters, computers that are all aligned closely. Right now, commanders are adjusting those headquarters to achieve the social distancing that's required to be able to mitigate the risk and continuing ongoing operations. That's going in all of our headquarters, our operations centers that do global operations. On the flying hours, right now we're able to we're continuing undergraduate pilot training, and I'm leaving it to local commanders to adjust their flying schedule based on the 3 priorities the Secretary of Defense gave us, right? Which is ensuring that we take care of our people, make sure the mission happens, and then be good partners with our teammates as we do a whole of government response to this. For wing commanders, especially those that are in our main operating bases, they have established close relationships with community leaders, and the community leaders are dealing with our issues downtown, and these are very often where our airmen and families live, work, and play. So they're going to adjust the flying hour program and the flying hour schedule locally, and I don't expect one size to fit all. I don't expect Clovis to look like Tinker, to look like Eglin. I expect each base to actually make a mature, prudent decision on flying hours, and I think it's our job as a staff and my job as the chief to back them up and get them what they need to execute.
Okay, we're going to go to Jeff Schogel at Task and Purpose, and then we'll finish up with Abraham at Washington Examiner.
Thank you. Thank you for doing this. I just wanted to clarify. There are 7 cases in the Air Force. Are these all active duty, or are there National Guard and Reserve airmen in addition to that? And can you say where the airmen who've tested positive for COVID-19 are stationed? Thank you.
I'd say, yes, right now they are active duty. Do you want to jump in on any in terms of locations? I don't know right now we have the exact locations as we go forward.
Jeff on that.
Yeah, we'll get that to you though. And you had a second part of your question?
Go ahead.
My question is the 7 airmen all the airmen with COVID-19, or are there Guard and Reserve airmen in addition to that who've tested positive for COVID-19? Thank you.
Yeah, no, it's a good question. Because this is an ongoing assessment daily, I'll tell you what I'd like to do is I will get you all that number. We'll follow up on that.
And Chief, starting within the next 24 hours, we'll provide regular, frequent updates to the press on Air Force numbers.
Okay.
And then let's finish up with Abraham from the Washington Examiner.
No question at this time. Thank you.
Okay, great. Bob, last question.
General, just wondering whether this situation is limiting your ability to recruit right now. Can you keep recruiting stations open and so forth, and interacting with people?
No, Bob, it's a great question. So far, nobody has reported any issues with recruiting. But common sense would say, as the nation, limits its movement, at some point that is going to have an impact. What it means is that we've got to do more outreach going there. And I've kept our director of personnel here, and he hasn't had a chance to answer a question. So I'm going to get him up here and give him a chance here on recruiting.
Well, thanks, Chief. On that question, Bob, first, we're lucky enough, right, that we have a little bit of sort of reserve in the tank. We have what we call the delayed entry program, and we've got about 4 to 6 months worth of folks who were on future dates ready for recruiting and being able to ship to go to basic training. So there's a little bit of reserve there to take place. As the Chief said, over time, we would expect that we're going to have to do a lot more outreach from a electronic standpoint and a virtual standpoint, because if it continues this way, certainly with the movement, limits on movement, we're going to have a little bit of impact to recruiting over time. But right now, we're still in a good place. Folks are still going. Schools closing will be a problem, right, for contact and those kind of things. And so over time, we're definitely going to see some challenges, but we think we'll start to work our way through in more of a virtual presence and be able to do that.
Are you already doing that now?
We are. I mean, that's already been part of what we do. There's a lot of online outreach, right? There's a lot of social media and things that'll happen. We won't have as much ability to do the follow-up and the face-to-faces that we have today, but we haven't really seen the impact yet.
I mean, you have actual physical recruiting stations still, right? I mean,
absolutely.
They've not been closed?
They have not been closed.
Thank you.
Chief, any final thoughts before we wrap up?
Yeah, just to maybe share with you, one story. So last Wednesday, I traveled down to San Antonio, Joint Base San Antonio, and it was actually the morning after we'd received a number of folks off of Princess Cruise Line. And so I had a chance to meet face-to-face with the HHS leader, Skip Leitner, and his team, the CDC team that was there, the doctors that were there, and then there was a team, New York One, led by Mr. Diamond, who were actually taking care of all of the passengers that as they went through. And I will just tell you that it was a real positive experience in terms of seeing the professionalism. I want to just give a shout out to the HHS team that I saw at work there. I mean, it made you proud to be an American. Skip Leitner is an engineer trained in this, and these are like our Air National Guardsmen, right? They're called up, and in an hour's notice, they pack their bag and they head into a crisis. And so everyone I met there was doing something else full-time in their civilian role and then joined HHS to do this. And so it was a very impressive operation. One of the things that we do, of course, is we bring to that team a lot of local connections. And the wing commander down there, the Joint Base San Antonio commander, Brigadier General Laurel Lindemann, who's one of our best and brightest, has established this great relationship with the mayor, Mayor Nuremberg. He joined us for the day and got to see the operation in action. And so this is what we do. We roll in with our sleeves up and help doing defense of civilian support agencies. In this particular case, HHS. And I was really impressed with the operation I saw there in San Antonio.
Thanks, everybody. Have a good day.
Thank you very much for doing it.
Here are the top 10 things you can do if you think you might have coronavirus or COVID-19. 1. Stay home. 2. Monitor your symptoms carefully. If they worsen, call your healthcare provider. 3. Rest and stay hydrated. 4. If you have a medical appointment, call ahead and let them know you may have COVID-19. 5. If your symptoms are severe, call 911. 6. Cover your cough and sneezes. 7. Wash your hands often. 8. Stay away from others in your home. Use a separate bathroom. 9. Avoid sharing personal items. And 10. Clean all surfaces that are touched often. For more information on COVID-19, visit cdc.gov/COVID-19. Let's take care of ourselves and each other.
Okay, well, good afternoon, everyone. I'd like to provide an update on DoD's coronavirus efforts as we continue to focus on our 3 priorities: protecting our troops, their families, and our personnel; 2nd, safeguarding our national security missions; and 3rd, supporting the administration's whole-of-government approach to addressing this national health emergency. At the same time, I want to assure the American people that the United States military remains ready and capable of meeting all of our national security requirements. I just returned from a visit to Fort Detrick to see firsthand how DoD doctors and scientists are advancing vaccine and treatment efforts to combat the coronavirus. I was briefed on the Army Medical Research and Development Command's cutting-edge COVID-19 response, and then I visited the Army Medical Research Institute of Infectious Diseases to learn about its ongoing experimentation and testing. The Army's work on a vaccine is one of the many ways the Department of Defense is supporting President Trump's whole-of-government approach to fight the virus and substantially slow its spread. Many of the policies and guidelines we've released go hand in hand with the President's 15-day plan. We have issued international and domestic travel restrictions to all DoD personnel and families that should dramatically reduce potential exposure to the virus. Inside the Pentagon, we are practicing social distancing, minimizing person-to-person interaction, and, wherever possible, conducting virtual meetings. Employees who exhibit any symptoms of the virus are instructed to seek appropriate medical treatment, stay home, and telework as needed. Yesterday, I held 2 sessions with the department's senior civilian and military leaders and briefed Vice President Pence, Secretary Azar, and other task force leaders on recommendations for how DoD can provide additional medical and logistical support during this national health emergency. I'd like to highlight several of those today. First, the Department of Defense will make available up to 5 million N95 respirator masks and other personal protective equipment from our own strategic reserves to the Department of Health and Human Services for distribution. The first 1 million masks will be made available immediately. Next, we are prepared to distribute to HHS up to 2,000 deployable ventilators for use as needed. These machines are different from their civilian equivalents and require special training to operate, but we are committed to supporting HHS's requirements in any way we can. Third, the department has made our 14 certified coronavirus testing labs available to test non-DoD personnel as well, and we will soon offer 2 additional labs for that purpose. We hope this will provide excess capacity to the civilian population. Finally, we are considering activating National Guard and Reserve units to assist states with planning, logistics, and medical support as needed. In my conversations with governors and members of Congress about DoD's resources, I've made it clear that we will continue to support the administration's comprehensive efforts and the country every step of the way while ensuring our nation's security remains the top priority of the Department of Defense. I recognize our decisions impact service members and their families, and I want them to know that we're all in this together. If we can dramatically reduce the spread of the virus over the next 15 days, together we can help restore public health and the economy and hasten a return to our normal way of life. As circumstances evolve over the coming days and weeks, we will continue to take every necessary precaution to protect our forces, to safeguard our national security capabilities, and to support the President's whole-of-government fight against this virus. These are DoD's priorities, and we remain focused on them. Thank you, and I will open it up this time for questions.
Mr. Secretary, you mentioned you're considering, I believe you said, activating the National Guard. Are you talking about federalizing the National Guard? And also, could you explain in a little more detail what was said this morning in the White House about using or calling on the Army Corps of Engineers to help with either construction or renovation of facilities?
Yeah, first on the with regard to the Guard and Reserves, we're looking at all the requirements as they come in. We're funneling those into a central point. As you know, right now we have, I think, 18 states and over 1,500 Guardsmen activated at different parts around the country. And so as we get requests in, we will look at activating them if we need to at the federal level or using the reserves, whatever the case may be. But we want to be very supportive with regard to our prioritization in terms of supporting the American people and the governors. With regard to your second question, I did not have a chance to observe the news conference, but my view is I'm more than willing to send the Army Corps of Engineers out to work with states and to see what we can provide, what we can offer. As you know, the Corps of Engineers is a contracting body that does program oversight and work, and if we can be useful, if we can help, I'm certainly willing to provide that service.
Sure. If I could just follow up, what are we talking about in terms of magnitude of active duty troops that could be used? Are we talking 10,000, 20,000, 30,000? And are you, or are the hospital Navy ships preparing to sort of deploy to assist with non-coronavirus cases? So right now we're really focused on Guard and Reserve in that order. We haven't looked, because there hasn't been a need yet, a request for active duty. So we'll take all these requests in due time. With regard to the hospital ships, there are two. As you know, the Comfort is on the East Coast, the Mercy on the West Coast, in Norfolk and San Diego, respectively. The Comfort is undergoing maintenance, and the Mercy is at port. We've already given orders to the Navy a few days ago to lean forward in terms of getting them ready to deploy. They provide capabilities, but much like what DoD does provide, our capabilities are focused on trauma. And so whether it's our field hospitals, whether it's our hospital ships, they are focused on trauma. They don't have necessarily the space, the segregated spaces you need to deal with infectious diseases. And so one of the ways by which you could use either field hospitals, the hospital ships, or things in between is to take the pressure off of civilian hospitals when it comes to trauma cases, is to open up civilian hospital rooms for infectious diseases. Now, for us, the big challenge, though, isn't necessarily the availability of these inventories, it's the medical professionals. All those doctors and nurses either come from our medical treatment facilities or they come from the reserves, which means civilians. And so what we got to be very conscious of and careful of as we call up these units and use them to support the states, that we aren't robbing Peter to pay Paul, so to speak. So what I don't want to do is take reservists from a hospital where they are needed just to put them on a ship to take them somewhere else where they are needed. So we got to be very conscious of that. And as I've spoken to a couple governors today, we talked a little bit about that. And I think people are beginning to understand what that trade-off means.
You know, at the White House today, they said they don't want to have the Guard go everywhere, I guess. They said let's focus on the hot spots. So that would presumably be California, Washington State, New York. Is that kind of where you're looking at early on to provide? Well, keep in mind the Guard is already available to the governors. They know that. They have their tags and everybody, so it's a resource available at their fingertips. What we want to do is make sure they understand all the capabilities of the Guard, how it may best be used. I've had a chance to talk to General Langell, who's director of the National Guard Bureau. We've talked a few times. He's talking to the tags. He's having multiple phone calls each week to cross-level. So that is available to them. I think, in some ways, we want to be the last resort, right? We're the ones when everything really is neat. We can come in rather than being the first and really help enable through the Guard and Reserve to play that role initially. And also I'm hearing that there's talk of maybe appointing a senior officer, maybe a 3-star, to coordinate among all the various federal agencies. Is that something you guys are considering?
Well, the two principal representatives at the day-to-day meetings with the VP and his task force are General Hyten and Deputy Secretary of Defense Norquist. Those are our representatives. General Hyten has a lot of capability. He can tap into all of DoD as he sees fit. Of course, we have NORTHCOM, who supports in terms of the Northern Command AOR. But this isn't like a hurricane where you can pick a general. This is nationwide. So I think what you're going to see is you'll see whether it's local commanders or tags in this case stepping up and as their states encounter these challenges and them being the focal point at the state level.
Courtney?
Can you say a little bit more about the 2,000 deployable ventilators? How many, I'm assuming that takes uniformed service members to operate and train and whatnot. How many would that take, and where are they coming from? And can you say where they're going yet? Or presumably New York, but...
No, I can't say where they're going. We've made them available to HHS. HHS would have to determine the prioritization. They are in stocks in some cases. We'd have to get you more detail on where they are, but obviously they're spread out to support our medical deployability. And yes, these require some special training. What we'd have to do, and I informed when we talked about this the other night with the Vice President and his task force, is we'd have to do a train the trainer, if you will, maybe provide some people to make sure that the civilians who would use them know how to use them properly. They're unique in terms of deployability. They got single-use functions in some cases, so they are different than what you would find on the civilian end because they're meant to be deployable. Right?
So would it be 2,000? I mean, presumably if it's 2,000 ventilators, is that 2,000 service members who would have to be used to train?
I would be speculating, but I would say no. I would say one person can train a multitude of people to learn how to operate them, and maybe you have them outside as an outside, to help with maintenance or things like that. But I don't think the numbers, we could do the math and get back to you on that, Courtney, and see.
Jennifer?
Can you give us an update, Secretary, as for about what Fort Detrick has found in terms of their vaccine? How far along are they? And since you're encouraging people to telecommute, why did you feel the need to be there in person and have meetings with people in person? Shouldn't that commuting start now?
Well, we're doing a lot of telecommuting every single day. I telecommunicated with the Deputy Secretary of Defense this morning from my office to his office. So when I went up there, we had all the social distancing stuff worked out, the space. But the chance to talk to the doctors face-to-face, and I wanted to see their labs, I want to see where they're working, is really helpful to me to get an understanding of what they're doing. So we put all those precautions in place. If anybody knows how to do it, they know how to do it. What I will tell you is they're working out on a number of fronts. As many of you know who've been here before, they've been very successful in the past, whether it's dealing with Ebola or Zika. They have incredible capabilities. They're well-knitted, extremely well-knitted into the interagency efforts. Their relationships with either Dr. Birx and Dr. Fauci are remarkable. And in terms of their ability to understand the virus, what it does, and they're at the point too in terms of the ability to soon purchase machines that could do the testing at incredible levels of capacity and throughput, is one of the things that they briefed me on that should be coming online in a couple months or so.
But how far along is the vaccine?
I think they gave me the same numbers that they gave all of you, 12 to 18 months, the normal course. As I understand it, there's some private actors out there who think they could do it quickly. But in terms of how we do it, it's looking at 12 to 18 months. And of course, where they can provide support is if somebody does develop a vaccine, we could run it through our system very quickly as well and support those efforts.
Barbara?
Mr. Secretary, two questions. First, could you bring us up to date when you talk about the Corps of Engineers, your latest assessment of what are the next steps are with the state of New York? Because Governor Cuomo has been so open publicly about his request. But first, I wanted to ask you, you talked about using the U.S. military active duty, the Defense Department, as, in your words, a last resort, not the first resort. Mm-hmm. I do want to press you on a bit on that, because the country's being told this is unprecedented, really dire potentials are being sketched out to the American public. Is it, in your view, is it time to think in non-traditional ways about using the active duty force? Should it be the last resort?
Well, when I talk about active duty force, I don't mean about people per se supporting in terms of planning logistics. I'm thinking about is our medical capacity with regard to our treatment facilities, things like that. We have to treat our own populations. Our own populations will likely be, in terms of beneficiaries, susceptible at the same rates as the civilian population. So we provide a little bit of flex. If you compare us to VA, they have many, many more hospitals. So that's kind of how I think about it. We got the Guard is available to handle stuff, and the active component will stand. We're ready to support in any which way we can. I'm just suggesting I think a lot of this has to begin at the state and local level in terms of in helping enable them.
Do you think that the military population, very often described in this room as young and healthy, is susceptible to the virus at the same rate as the civilian population? And I would like you to address New York if you could.
Well, don't turn me into a doctor that I'm not, but I will tell you what I said before is we have a very young and healthy and fit military population, which seems to imply, based on what we've seen so far, that they are less likely to contract and show symptoms at the rates of people older than them. Now, of course, many of them, another part of our population are dependents and beneficiaries who range from young kids to senior citizens. So I got to worry about that population as well. That's about 3.8 million people who live within 40 miles or so of our 36 military treatment facilities. So I'm looking at that population as well. With regard to the uniformed people, I do think they are very fit. I think that they will fare well throughout this. We watch them and protect them, and as need be, test them. But again, I think in terms of the military population, they'll be fine. With regard to New York, I hope to have a call with the governor here sometime soon. I've been trying to talk to I've spoke to 2 governors today, find out what his needs are. As I speak to governors and others, I say, tell us what your needs are, and then we'll figure out the best way to meet them, whether it's logistics, planning, medical, whatnot, and then we can look at the various ways we approach it. Is the National Guard the first place? If not them, then the reserves. Active component is there as well to support. So we kind of triage the problem to make sure that we understand what all the trade-offs are. Again, what I think's been explained to you all about field hospitals and hospital ships, and the simple fact that many of those medical professionals who staff those units come from the private sector is something that most people are not aware of. And we got to be very careful that we don't take from one part of New York medical professionals who are needed to stand up a field hospital simply to help another part of New York, unless, of course, the governor recognizes that. And of course, we can also do state-to-state stuff where states share. And I had a conversation earlier today about that. So we're looking at putting everything on the table.
All right, we're going to try to go to the phone line, and we'll take our first question from Jeff Schogel from Task and Purpose. Jeff?
Thank you very much. It has come to our attention that despite the fact that the Pentagon is teleworking, commanders continue to have all-hands formations and town halls to discuss a variety of topics. Will the Defense Department order a moratorium on all large gatherings like town halls and all-hands formations?
The short answer is no, at least not at this time. I trust the commanders to lead their units and take care of them appropriately, and that has not been raised to me as a problem at this point in time. So again, my view is the commanders have the authorities they need to take whatever precautions, but while at the same time ensuring the readiness of the troops and the capabilities of our formations.
Okay, Missy Ryan from Washington Post.
Thank you. Secretary Esper, can you talk a little bit about the testing of service members that's being performed now? It seems, according to the most recent numbers we've seen, there have been about 500 people tested. Do you think that is adequate in order to detect the spread of the virus within the military community and halt its spread? And what are the criteria for testing?
Well, we can get the surgeon, the Joint Staff Surgeon, back up here to talk about that, to give you the exact details. My view is if you are symptomatic, you should definitely be tested. Otherwise, there's no plans to test all 1 million or so active duty personnel. That is, I don't believe, something we need to do at this point in time. But again, I'd rely on the Joint Staff Surgeon to kind of give us, to fill you in with regard to how that is. But if you're symptomatic, you definitely should be tested. In some cases, if you've been exposed, you should be tested, but we're not at that point yet to order across the formations.
Lee Hudson, Aviation Week. Okay, back to the room.
Mr. Secretary, could you give us some sense of timing here? How long does it require you to activate a reserve unit? If the governor of New York wants you to get the Army Corps of Engineers contracting to renovate hospitals or build new ones, we learned with the wall that still is a contracting process that takes time. So how long would it be before the U.S. military really started having an impact in terms of hospital beds?
Yeah, it's another great point that as I talk to people, I try and share with them. So let's take your second part first. With the Corps of Engineers, they do great work, very good program managers, but they have a number of federal rules and regulations they follow. They have a very expansive contracting process, and that takes time. The Corps of Engineers does not build projects. They contract others to do the projects. So my hunch is It would probably be quicker if it's done at the state or local level. But nonetheless, I don't mind offering up the Corps of Engineers to come to a state to talk to whoever a governor wants them to speak to about with regard to renovating buildings or whatnot, to see if we can do it quicker. We're prepared to do that. But I think at this point the key is speed. But again, I need to have those conversations with the governors and others. With regard to your first question, you're right. It takes. Look, I spent a lot of years in both the Guard and Reserve, and it takes time to activate people. Depending on the type of unit, it's you have to activate the person, but then you have to draw equipment. You have to do any number of things, and then in all cases, you have to again be very careful that you're not pulling somebody out of a part of the civilian sector where they're needed. We keep talking about medical professionals, but it could be law enforcement. It could be firefighters, whatever the case may be. So that takes a little bit of time, too, to make sure we're making the right decisions with regard to who we call up.
So you're describing a process that sounds like it's going to take weeks, not days.
Well, it could, depending on, I don't have any hard requests, maybe one or two right now, but if you're thinking about calling up the Guard Reserves, it's not hours or days, it's probably days or weeks, and more like weeks. But it depends on the type of unit, where they're located, what they would have to bring to the mission, et cetera.
What are the hard requests?
Let me go to somebody else.
Thank you, Mr. Secretary. At the White House briefing today, the President suggested that there's actually been some discussions about potential sites for field hospitals. Have you been advising on where these sites could potentially be, maybe Washington State? And then secondly, on the ventilators, with the 2,000 that you're sending out, can you give us a sense of if there's greater need than that, if this gets worse, how much further can DoD surge before it needs to reach out to maybe the private sector or other places?
Well, I think again, second question first, we can offer up to 2,000 doing that. That's why I like to say the key thing right now, when you look at the numbers of people that are projected that may need ventilators, 2,000 doesn't put much of a dent into it, but we can offer what we have. But I think the key thing is the private sector, the manufacturing side, whoever makes medical machines of this type, is how do you prime that pump to get the production? Because we're simply not going to be able to meet the demand if the demand fits some of the profiles that we've seen the CDC brief. And then location of field hospitals. Again, I think it's a case-by-case basis. It has to depend on a conversation with the governor or the state or local authority. My view is the best use of our field hospitals, because they're geared toward, is trauma. So ideally what you would do is locate it somewhere, maybe next to a hospital, whereas trauma patients come in, instead of going into the hospital, they would go into the field hospital, where we could treat the broken legs, the lacerations, the falling down, hit your head type of stuff. We can handle them in our big open bays. We have our doctors that can do that. And if you come in for a COVID, we've now freed up rooms for you to go inside the hospital, where you have segregated rooms with bathrooms and all those things you need to treat infectious patients. So, not a doctor. I was an infantryman, not a medical professional, but my hunch is you'd want to do some type of co-location next to where medical facilities are. But that all has to be worked out with the local, state, and or municipality to make sure how can we best support, if that's the support they need.
Last question. Sure, I heard you right. 2,000 is the upper limit.
That's what we can offer right now. That's right.
Last question. Thank you. Pat Becker from Defense One. The Defense Advanced Research Projects Agency currently has a program to develop an antigen. It's kind of like a vaccine, but a little bit more proximate. It can potentially shield troops or anybody else from contracting the disease for a period of time until a vaccine becomes available. Can you describe, based on your conversations today, what the readiness level is, or the level of preparedness for any sort of COVID therapeutic that might be in development by the U.S. military?
Yes, I'm not tracking the DARPA one. I hope to go see them sometime here soon to find out where they are in terms of their work. They are part of all this too. But with regard to USAMRIID, where I was today, they're working on two parts, both the vaccine and then the treatment piece, which is the therapeutics and that. So they're moving along on both fronts. I didn't get too detailed of a briefing on the second part. I focused a lot on the vaccine side. So, but that's something we can get the Joint Staff Surgeon to come and brief you all about. Okay?
Thank you.
Good.
Can we just get an update on the situation in Iraq, given
We'll do that another day. Today's coronavirus, that's my focus right now. Thank you all.
there was a third attack in
teammates, we know you have lots of questions about the impacts of COVID-19 to your situation, whether it's PCS, TDY, school, or leave. Our team is working hard to keep the details updated as quickly as possible. We want you to keep in mind that official resources will have the most current and accurate information. Sites like afpc.af.mil and af.mil both have dedicated pages for COVID-19. Now, if your travel is projected to be impacted by the DoD stop movement, you should receive official guidance through email. Maximum use of telework is encouraged for all eligible personnel. Talk to your supervisor to determine status and reporting requirements. Our priority in this time is to take care of you while also doing our part to minimize the spread of this disease. Let's all do our part to take care of ourselves and each other. Remember this, just because a teammate is quarantined, they don't have to feel isolated. Reach out, check on your wingman. Thanks for your understanding as we navigate this tough time together.